I've called this presentation The Significance of Mother-Infant Observation for a Better Understanding of Our Analytic Patients. In Britain, we are very familiar with mother-infant observation as an essential part of the psychoanalytic and psychotherapy trainings, but this is not the case in other countries. Some other psychoanalytic societies have considered including it as an obligatory part of their training, but very few appear to have done so, though it is sometimes offered as an optional extra. Occasionally, some students or already qualified analysts arrange by themselves to do a baby observation out of their own interest, and this was the case of some Finnish analysts whose experiences I will draw on later. Some years ago, I was invited to give a paper to the Zurich Psychoanalytic Society because one of its members wanted to encourage them to think about introducing mother-infant observation into their training. I thought that writing the paper would be a fairly straightforward task, but the difficulties began to surface when I started addressing the specific title I had been given, The Significance of Baby Observation for Analytic Work with Adults. I decided to speak to several friends and colleagues, and to my increasing surprise, everyone said the same thing. They were all completely convinced that the experience of infant observation helped them to understand their patients better, but they could not articulate exactly how. It seemed important, therefore, to address this common difficulty and try to understand it. This presentation draws on the Zurich paper in considering how and why mother-infant observation can enrich a psychoanalytic training. I will consider some of the benefits and pitfalls in the observation process and raise some questions about it and about how it can be both idealized and denigrated. I will also suggest that in addition to infant observation, observation of children beyond the age of infancy offers the most comprehensive psychoanalytic training. Some clinical examples will be given to illustrate the significance of both mother-infant and child observation in understanding patients of all ages, and I will try to address the difficulty mentioned above in being able to articulate clearly why it's so important. So what is infant observation? Usually we talk about infant observation, but it's more appropriate to use the term mother-infant observation. Just as Winnicott considered that there is no such thing as a baby, meaning the mother too has to be considered, one could say that there is no such thing as infant observation, only mother-infant observation. But for simplicity, I will use the term infant observation or baby observation as a shorthand in this talk for mother-infant observation. I'm also using the term mother both in its specific sense, mother as a person, but also in the Winnicottian sense of the environment mother. In other words, mother as the provider of the initial environment for the baby, who gradually develops more and more interest in his actual environment, including the world about him, his father and siblings, etc. It's the developing relationship of the baby with his mother and her relationship with him, and the baby's relationship to his father and other family members and the world around him that constitute the main focus of the observer. If you ask a teacher what most facilitates the learning process in his pupils, he will probably say it's the child's capacity to be curious and to be actively and personally involved in the learning process. I think this is equally relevant to training to become a psychotherapist or analyst. The personal training analysis is the cornerstone of any psychoanalytic training throughout the world, and the supervised training cases are similarly central. In both the training analysis and the supervised work with patients, the student is actively and emotionally involved in a specific type of relationship and is exercising his curiosity both about himself and about his patients. Something similar happens in the experience of being an observer of a baby in his family setting. The student is curious to observe the development of relationships within the family, especially between mother and baby, but also becomes involved in a relationship with each different family member. In my view, infant observation is not primarily concerned with learning about psychoanalytic theories of infancy. Observing a baby in his own home may give the opportunity to consider and question the relevance of the various psychoanalytic theories, but it certainly does not enable us to prove or disprove them. What it does is to offer one individual the opportunity to observe over time the development of one baby in relation to one mother and one family. I emphasise the one individual observing in one setting because an observation, like the psychoanalytic relationship itself, is a personal experience. Like analysis, it's unique because it involves individual people relating in individual ways in a particular and limited setting. Although some general elements may be common to most observations, and by observations I'm referring both to infant observation and the observing we practice with our patients, exactly what is seen and also what is not seen will depend largely on who is doing the observing as well as who is being observed. This point became abundantly clear to those who attended a conference organised by the Association of Child Psychotherapists in London way back in 1989. Video extracts of an infant observation were shown at the conference, and 4 analysts, each with a different theoretical orientation, namely contemporary Freudian, independent, Jungian and Kleinian, presented short papers in which they described and discussed their understanding of the baby in question. The conference showed quite clearly how the theoretical eye of the observer shaped what the observer saw. It was striking that each analyst seemed to be describing a very different baby and mother. There's a parallel here to what the therapist thinks he sees in his patient. It's important that we develop the capacity to be open to discovering something unexpected in our patients and not let ourselves fall into the trap of seeing everything about our patient in terms of our own particular theoretical model. The British analyst Marianne Parsons describes this as, quotes, an attitude towards the unconscious which will help us not to be limited only to ways of seeing which we are familiar with already. Close quote. The main point I want to make here is that infant observation as part of a psychotherapy training is not so concerned with learning about theories of infant development, but is much more about the personal learning experience it offers, which I'll come to later. However, this is not to say that thinking about theories of development is absent from the experience of baby observation. The observer will certainly want to think about the impact of the mother's handling of the baby, the influence of the parental relationship, as well as the baby's impact on the mother and the family, how patterns of object relating might develop, how the baby's self and ego appear to be developing, how early prototypes of defences might be observed, how the baby's curiosity and involvement in his environment is helped or hindered, and how the mother and the baby deal with such things as dependence, separation and individuation, etc. Some psychoanalytic theories may come alive and thus have a more vivid relevance, whereas other theories may be questioned more critically. When the observer becomes involved in the intimacy of the mother's and baby's world, he becomes vividly aware of the significance of what appear to be small and simple day-to-day experiences or shapes which gradually form the overall pattern of mutual adaptation between mother and baby. The quality of the first love relationship between mother and baby forms the template for the basic shapes which mould the general pattern of the baby's development, capacity for the development of the self, for experiencing and managing affects, for curiosity about the world, for relating to others, for empathy and for play. One can see the emerging separateness of the baby's individual personality when he turns away from the mother, and one can see the significance of the father's different style of relating with the baby. I'll now turn to a brief history of psychoanalytic infant observation. A TV programme in Britain on Leonardo da Vinci some years ago showed that Leonardo did not have the typical formal education of his day, but roamed around the countryside near his home as a child, spending his time looking at and being curious about nature. In the programme, it was suggested that the absence of formal education enabled him to be free from the constraints of received knowledge to observe, wonder and think for himself. Leonardo spent his life trying to learn how things were made and worked by carefully observing natural phenomena. Throughout her life, Anna Freud also placed a strong emphasis on the importance of observation. She started systematic childhood observations in 1937 in the Jackson Nursery in Vienna. This nursery was set up to provide daycare for very young children and also to provide a setting for psychoanalytically informed observations. The children were mostly aged 18 months or more, but in the first year, a young baby was also part of the group. When Anna Freud moved to London, she and her co-workers continued recording and discussing observations in the Hampstead War nurseries, though these mostly focused on specific aspects of a baby's day, such as sleeping and feeding patterns. Similarly, Winnicott did not make baby observations in the strict sense of the term, though he often noted in his writings what he found from his observation of infants whilst working as a paediatrician. The first person to include infant observation as part of a training was Esther Bick, when in 1948 she introduced it into the training of child psychotherapists at the Tavistock Clinic in London. Thereafter, each accredited training course in child psychotherapy in Britain included infant observation as an essential element by putting it into the curriculum of the pre-clinical course before the students took on supervised training cases. Later, the adult psychotherapy trainings followed suit, with the British Institute of Psychoanalysis adding infant observation to the pre-clinical curriculum in 1960. Since students are in analysis while they undertake baby observations, there can be a flow back and forth between the child in the adult, on the couch, and the baby they're observing. This can enrich both experiences. Because infant observations in the child psychotherapy trainings last for 2 years, unlike in the adult trainings in Britain where they only last for 1, students have the opportunity to observe a baby well beyond the first year of life. This allows time for the student to process the personal experience of the observations. It also offers an ongoing perspective of the baby's development and of his relationship with members of his family. Without this, there might be more of a tendency to adopt a rigid theoretical viewpoint that considers only the prime centrality of the first 6 months of life, thus neglecting the great significance of later development. In the observation seminars, students not only get to know each other's observed babies and families, they also get to know their fellow students quite intimately. A kind of bonding can occur within these groups, which, if it goes well enough, can help the students who are new to the training to form a sense of belonging to the organisation. But the intimacy of the seminar group can also engender problems. For example, one student who is experiencing anxiety about the development of her observed baby and is perhaps feeling a bit hostile to the mother might envy another student whose observed baby seems to have a better mum. Or a student may feel that a colleague is idealising the mother-baby relationship and failing to notice the difficulties. But if the seminar leader can establish an atmosphere of tolerance and trust, such tensions within the group can become useful learning experiences, and the students can listen to and learn from each other. Students' relationships with their own siblings and parents may be displaced into the dynamics within the seminar, and this, of course, can provide valuable material for their own analyses. A tendency to idealise or denigrate the observed mother may also be affected by the student's own childhood experiences with their own mother. It can also reflect an intense feeling that there is or should be a perfect mother. The seminars, as well as the observational experience over time, can help students to appreciate more fully the concept of the good enough mother. Writing the required paper about the mother-baby observation encourages students to consider the overall patterns of development of the baby and to formulate what was observed in terms of theoretical understanding. But, perhaps much more importantly, it helps the students to process the personal experience of the observations in relation to their own feelings and attitudes and their role as an observer, and how this may have affected the family. A senior training analyst within the British Society, Elizabeth Spilius, taught infant observation at the British Society for many years, and she kindly told me the history of baby observation within the British Society and how it took some time for the initial objections to be overcome. At first, analysts objected to infant observation because they thought, firstly, it wasn't analytic, that observational skill had nothing to do with the unconscious, and that therefore infant observation did not prepare the student for analytic material. And secondly, they worried that it would interfere with the delicate relationship between mother and baby, and that it would be unfair to the mother. These initial objections, in fact, diminished as baby observation became more fully understood. Although it was found that the observations did not throw much light on psychoanalytic theory or offer any proof that would enhance any one aspect of theory in preference to another, the value and experience and significance of the student's experience of being an observer soon became recognised and fully appreciated. A strong correlation was found between a student's capacity as an observer and his capacity for clinical work once he started seeing patients. It became clear that the student's emotional reactions to the situations of being an observer taught them a lot about themselves. It offered them a sense of discovery and an opportunity to learn to manage their own anxiety and to notice things that they could not yet understand, valuable learning experiences in preparation for being an analyst. What was most striking was that the students soon noticed how very judgmental they were about what they observed. The skill of the seminar leader was in being able to wait and to help the students to tolerate their own shocked reactions to the mother of their observed baby, as well as their shocked responses to the judgmental attitudes of their fellow students. Gradually, the students discovered that their judgmental stance often revealed more about their own attitudes and conflicts than those of the observed mother and baby. And the objection that baby observation will be damaging to the mother-baby relationship was also recognised to be unfounded. It was discovered that most mothers who were very insecure or who felt easily attacked either chose not to have an observer in the first place or broke off the contact quite early on. The majority of mothers who chose to have an observer felt supported by the experience and welcomed and enjoyed the observer's visits. I now want to try to address the question, why is it so difficult to articulate how the experience of baby observation enhances our understanding of patients? Factual events are usually quite easy to describe, but a personal experience with an emotional meaning can be harder to articulate. It's harder still to articulate exactly how one makes use of personal emotional experience. How many of us would be able to articulate exactly how we make use of our own personal analysis in helping us to understand ourselves and our own patients better? If the training analysis has appropriately involved an emotional relationship with the analyst, aspects of that relationship, as well as the analytic process itself, will become internalised. As the internalisations occur, we change. The internalisations are, by their nature, now part of us. Lines from a children's poem by Walter de la Mare express the process of internalisation rather nicely. The poem goes, "It's a very odd thing, as odd as can be, that whatever Miss T eats turns into Miss T." True learning, by which I mean emotional learning, not just intellectual knowledge, involves similar internalisations that are not easily accessible to conscious thought, but their derivatives may arise preconsciously during work with the patient and provide a clue to something we might otherwise have missed or failed to understand. Aspects of the baby observation become internalised experiences which we draw on, often without conscious thought, to help us to get in touch with the infantile aspects of the patient, especially in the transference. Because they are not fully conscious, this may explain why it is hard to articulate exactly how we make use of them in our clinical work. The next part focuses on the significance of infant observation for a better understanding of our patients. Observing a good enough mother in tune with her baby is a most moving experience. Conversely, observing a mother when she's out of touch with her baby is excruciatingly painful. These emotionally stirring experiences highlight the significance of the mother's capacity to feel with the baby, often conveyed by her tone of voice, and impress us very vividly of our impact as therapists or analysts on our patients, whatever their age. Sometimes an image will come to my mind when working with a patient that stems from an infant observation. For example, a young woman of 24 was consistently provocative towards me and very dismissive of what I said. I began to feel increasingly irritated that she was rejecting what I thought of as very careful interpretations, and then very guilty that I was not being a good analyst who could offer her useful interpretations. But I was out of touch with my patient. What finally came to mind was an image of a baby who was hungry but who kept turning away with a disgusted, cross look on his face from the spoon of food that his mother was offering him, because he wanted more independence and self-reliance. Then the image of two different styles of mothering from the baby observation seminar during my own training came to mind. One was of a mother who was impatient to feed her baby and kept trying to make him take the food, so that there was a stubborn and unhappy impasse. And the other was of the mother who was puzzled because the baby was hungry, but was waiting patiently without offering the spoon again until the baby was ready to move towards the spoon himself. These images helped me to recognise what might be happening in the transference and counter-transference, and to empathise better with my patient's sense of my over-helpful interpretations, which she was experiencing as intrusive, and with her wish to try to be more independent and self-reliant. I spoke with her about how upset I thought she was that I hadn't been listening carefully enough to her need to find things out for herself, and the atmosphere in the session began to change. We had been at an impasse, but instead of fighting and dismissing me now, she became more reflective. We could become allies again, instead of opponents, in what had felt like a power struggle for her and me. One could think here of how I was unconsciously wanting in the countertransference to be fed with the feeling that I was being a good analyst by my patient's acceptance of my interpretations. The experience of our own analysis, as well as of empathising with the baby and mother in infant observation, can help us to recognise such countertransference enactments. I'm now going to describe very briefly the general flavour of my own baby observation, which was of a mostly good enough mother with a healthy, resilient baby, together with some specific, meaningful images to show how the observational experience can help in working with patients. Mrs. K was divorced from the father of her eldest child, Peter, aged 11, and had 2 children by her current partner. Karen, the baby I observed, was just 1 year younger than her sister, Susie. Mrs. K was a practical, resilient and capable woman who loved her children and fought hard to do the best for her family, with few resources, financial ones. I was impressed by the affection between Mrs. K and her partner, and by his gentle and good-natured playfulness with the children. During the first weeks of Karen's life, Mrs. K, an experienced and confident mother, provided an environment in which Karen could feel lovingly and securely held. Mother and baby shared quiet moments of absorbed intimacy when Karen would gaze back at her mother in rapt attention, mirroring the mother's smiles. Mrs. K had no desire to keep Karen as a dependent baby, but took pride in her new skills and encouraged her shifts from dependency towards active mastery. Sometimes I worried that she didn't allow Karen enough dependency and was trying to shape the baby into someone like herself, self-reliant, coping and resilient. But over time, I noticed that Karen gained enormous pleasure from her new skills and was developing well as she took her first steps towards individuation. By 6 months, Karen had become more active and loved being free on the floor and could move surprisingly fast by rolling over and over, but she could not yet sit steadily without a supporting hand. Mrs. K wanted to help her to feel some confidence in trying to sit by herself. Knowing that the carpet was soft enough to prevent any hurt, she sat opposite the baby on the floor, allowing her to keel over on her side a few times. By reassuring and encouraging Karen, she helped Karen to master some of the fear of new or unexpected experiences, such as this. One of the predominant characteristics of Mrs. K's style of mothering was the balance she usually maintained between being non-intrusive and yet offering help when the baby couldn't manage independently. One image that struck me at the time and has remained vividly in my mind ever since was her characteristic way of approaching her children to pick them up. Smiling, she would hold out her arms, suggesting, "Coming?" She would wait for an affirmative response, indicating an invitation to be picked up without imposing herself on the child. This image, like that of the mother waiting until the baby made an active move to show that she was ready for the spoonful of food, which also came from the observation of Karen, sometimes comes to my mind when working with patients. Such images can remind me to wait until a patient seems ready for an interpretation, or better still, until the patient can find the interpretation himself. Two Finnish psychoanalysts, Raija and Timo, wanted to do a baby observation as it had not been part of their training. We arranged to have telephone seminars in which we discussed what they had observed, what this might infer, and how they felt. Occasionally we would discuss papers about infancy, but mostly we just tried to form questions in our minds about what they had observed. Sometimes we were tempted to jump to conclusions about something in the reports, but we tried to keep an open mind and remind ourselves that our thoughts were merely speculations. We were especially supportive of each other at the times when we felt anxious about the baby's progress. Raija and Timo continued to practice as psychoanalysts during their observations and were therefore in a good position to consider how the experience of the observations and the seminars influenced their active analytic work with patients. I shall summarise their experiences under 3 headings: sensitivity to infantile states, the capacity to tolerate doubt and not knowing, and finally the role of the observer. So firstly, sensitivity to infantile states. Intense feelings and primitive anxieties become aroused during the experience of baby observation. This is largely due to our mostly unconscious identification with the baby. But superego elements, often expressed as hostility towards the mother, and strong defences that aim to protect us from residues of infantile experience also play a part. It's very common for the student to talk of the observed baby and mother as my baby and my mother, because the intimacy of the setting can evoke aspects of the observer's own infantile experiences and of his early relationship with his mother and family members. This painful and sometimes shame-inducing experience can enable the student to develop more empathic attunement with his patient's infantile states, especially in relation to non-verbal material and regressed states of mind. Raya made this point when she said, and I'm quoting from something she wrote, "The experience of baby observation," she said, "helps me to see more clearly the infantile feelings and thus to empathise and get in touch with the baby self in the adult patient. For example, we can all read about the baby's need for the mother's presence and know theoretically about the anxiety that is aroused when the mother is absent. But observing this at close hand and allowing oneself to feel these feelings with the baby can increase one's empathic awareness, for example, of an adult patient's very deep distress over separations from the analyst, such as at weekends or holiday breaks." And an extract from Raya's observation illustrates this beautifully, so I'm going to read a short section from one of her baby observation reports. She wrote, "The little girl, Kay, is now 10 months old. Her mother went away for 3 days. When I visited during the mother's absence, Kay slept the whole hour. I was told that she'd been sleeping a lot while her mother was away, and that when the mother returned, Kay had not looked at her, only at the window. When the mother then went back out to the car to collect her luggage, Kay had cried and cried in absolute despair, as if it was all too much for her. For the next 3 days, Kay guarded the door, but then seemed to be able to settle and feel safe again. I visited them 1 week later," writes Raya. "Kay came to greet me with a shoe in her hand. We had played a game with her shoe on previous visits. She would give it to me and I would give it back. It was a very nice game, and now I thought she wanted to play it again. She came closer to me, holding the shoe in the air, and I felt I had to make a move to defend myself because I thought she was going to hit me. But she just stopped in front of me, holding the shoe high in the air, and looked at me very seriously. Then she turned round, crawled over to the wall, and began to hit the wall with her shoe. Her mother said, 'No, Kay, that will mark the wall.' Kay listened to her and stopped hitting the wall, then went over to her toys. She began to throw her toys in the air, listening to the hard noise they made as they fell to the floor. The mother seemed to understand what was going on in Kay's mind and said, 'Good girl.' I was astonished." Raya continues, "Kay was angry with her mother for leaving her, but she had good capacities to cope. She was a unit, a real person, who had the basis of a good relationship with her mother. This kind of experience in a baby observation can help me to understand my adult patients better. I can judge whether or not the patient can cope, whether I need to be an auxiliary ego for the patient, or whether the patient can handle the anxiety by herself." Raya relates the experience of observing Kay's anxieties and frustrations over separation from the mother to her work with an adult patient. She wrote, "I have a patient who tries to blame me for everything. When I have to announce a change, for example a different hour or a cancelled session, she wants to quarrel with me. Then I thought of Kay's anger as a response to her mother changing the routine by going away for a few days. So I told my patient, 'I can understand how upset you feel. It's too much for you to bear that I change your time.' Then I offered her an example of how a baby reacts to change or frustration, drawing on my experience of observing Kay." Raya said to her, "It's so very painful for a baby to have to wait for its food, but you are such an adult person that it's difficult to think that you can have very vulnerable feelings like a baby." Raya goes on. In this way, I can help my patient to understand her baby self better. It also helps me not to be tempted to quarrel with her, because I can empathise better with how she feels, and then we can begin to play again in the analysis. She goes on. When you've observed the baby, you can listen better to the infantile feelings of the adult patient, and you can appreciate what a big step it is to become a unit, a real person. It doesn't mean that you forget everything else, but if there is something in the patient's material that brings K to my mind, I find that I can listen with my observational ear too. Then I might go back to my observation notes, to my notes of our seminar discussions, and perhaps to reading more Winnicott. Having been emotionally affected by observing how Kay struggled to manage ambivalent feelings towards the mother, aroused by the separation, Raya could use this experience to appreciate her adult patient's ambivalence towards her in the transference. The observer, if she allows herself, may experience very intense feelings: pain, tension, helplessness, fear, confusion, sadness, rage, intimacy, serenity, delight, joy, etc. Such feelings contribute to the impact of the whole observational experience and can enrich affective understanding of our patients, if we can remember how important it is to observe our patients and be in tune with their anxieties, feelings, needs and fears. Here's another example to show how the emotional impact of baby observation helped Raya to understand her adult patient more empathically. This is an extract from the first home visit to a different family. Raya enjoyed baby observation so much that she did a second one. She wrote, "The mother is sitting with the baby girl. Her little boy, aged 17 months, is sitting on the floor nearby with 2 dummies, comforters. The father is also in the room. The little boy puts one dummy in his mouth, then the other, repeating this many times. He doesn't look at the mother or the baby. His father says, 'You have so many dummies. What a big boy you are.' The mother then leaves the room to give the baby a bath. The little boy follows and turns off the lights. The mother says to him, 'Can you be a big boy for money and turn the light on again?' But he doesn't, and he seems utterly miserable. When the mother breastfeeds the baby, the little boy turns his back on them and goes back to putting the dummies in and out of his mouth. Raya says, 'I notice how hard he is struggling to defend himself. The father seems to notice this too and keeps talking to him. The mother tells me, "Can you see how badly he needs the dummy?" And Raya writes, "I feel great pity for the little boy." The father then leaves for work, but the little boy runs after him to try to prevent him going. "I go up to him," writes Raya, "as the mother cannot because she's feeding the baby. After the father has gone, the mother and I have some coffee. The little boy is given some biscuits and makes a big mess with them on his face. The mother tells me sadly, 'He suddenly had to try to become a big boy for me when the baby came, but I realise he's still only a baby himself.'" Raya used this very painful experience of observing the little boy's jealousy of the new baby, his experiences of loss and his defences to try to deal with all this when working with an adult patient. This patient, when this patient was a toddler, she had a baby brother born into the family. The patient had never been able to talk about Raya's other patients because it aroused such anxiety and distress to see that she had other people to attend to. When Raya thought about this and digested it, remembering how painful it was to watch the brother of the baby she observed struggling with his jealous anger, she was able to convey her understanding of her patient's need to defend against such feelings. Previously, the patient had never spoken much in the analysis about her younger brother, but now said that she wanted to get to know him more and their relationship began to improve. A child psychotherapist gave a very nice example of how baby observation helped her to be attuned to one of her child patients. Ben, aged 5, usually loved to play in his sessions, but one day he seemed preoccupied and more solemn. He climbed onto the table so that his face was on a level with hers and just gazed into her face. He then gently touched her beads and the embroidery on her shirt. She told me that it reminded her of the way a baby explores his mother's face and body. Ben seemed then to feel anxious and got down from the table, saying, "I want to go now." Recognising that he might be experiencing some loyalty conflict, that he might be anxious that his mum would be angry with him about his love for his therapist, she said gently, "Mummy's okay. She's downstairs and will wait for us. We can stay and have the rest of the session." And this was sufficient for Ben to be able to remain for the rest of the hour. The next section concerns the capacity to tolerate doubt and not knowing in baby observation. It's quite common for students who are just starting a baby observation to feel at a loss, in a bit of a panic, longing to find facts or theory to help them make sense of their observations. Becoming able to tolerate the painful experience of not knowing without resorting to action or defensive intellectualization is one of the valuable learning experiences involved in baby observation and offers good preparation for working with patients. In any analytic work, we can fall into the temptation of making interpretations in order to help us feel more secure and to find some meaning to defend ourselves against feelings of helplessness and confusion. We may rationalise defensively that we are doing this to help the patient, but we may in fact be doing it to help ourselves. In the words of Ella Sharp, quotes, "We may detect in ourselves a falling back on omnipotence if, when we are baffled and uncertain in our work, we resort to the magic of words." In a baby observation, as in working as a therapist or analyst, we try to observe and speculate without making assumptions, and to watch over time for the confirmation or redundancy of our hypotheses. For example, it can be a very valuable learning experience for the observer to note that the baby can cope with external impingements, despite fearing that the baby's healthy development is in jeopardy. Abe Braffman made this point when he wrote, quotes, "Over the months, the observer gains a vivid notion of how behaviour or statements that one day appear to represent growth pathology will later result to have meant normal events in the developing person or relationship." Close quotes. An example from the seminar discussions by the other Finnish analyst, Timo, illustrates this. Timo observed a baby boy whose mother already had 2 sons from a previous marriage. These boys and their friends, as well as neighbours and the grandparents, were often in the home when Timo made his visits. So the home was often very busy and noisy, and we sometimes worried in our seminars that the baby, Jay, was not getting enough quiet, intimate contact with the mother. This concern was reflected in the fact that Timo himself often found it quite difficult to observe the baby, and instead got drawn into the hustle and bustle of the busy family life. It became more of a family observation than a baby observation, but we all learned from this. The baby's father sought Timo's attention, often talking to him during the visits, as if he felt left out and needy that his wife's attention was focused on the baby and her other 2 sons. When Jay was 10 months old, the mother became pregnant again, and our worries intensified. But Jay developed well, and we began to talk more in our seminars about the role of the whole family in shaping the baby's development. We noticed the importance of Jay's relationship with his older brothers and his grandparents, and observed Jay's capacity to make use of his entire emotional environment in coping with anxiety and change. Jay also made use of the observer by sometimes leading Timo to a place where they could just sit quietly together. This example illustrates a resilient baby's capacity to get the best out of what his environment offers and to develop good coping mechanisms. Observing a baby's capacity for adaptation and mastery can help us not to pathologize our patients, but to appreciate how they found the best adaptations they could during their development to cope with their particular situations. And now to address the role of observer. It seems most appropriate for infant observation to take place during the preclinical part of a psychoanalytic training because it offers the opportunity to learn to observe without knowing or enacting. And this is good preparation for work with patients. The parents and other children in the observed family will relate to the observer in their own particular ways, and the presence of an observer will inevitably have an impact on each family member. This alerts the observer to the ubiquity of transference relationships. Because strong feelings are aroused in the observer during the visits that needs to be experienced, contained, thought about and not acted on, the student can prepare for intense counter-transference feelings that will arise with patients. As A. Braffman said, quotes, "Infant observation offers a unique opportunity for the student to learn how his presence influences the events in which he participates, and conversely how he is affected by them." Close quote. A mother with a new baby is in a fragile, vulnerable state, and an observer who enters this intimate arena by visiting the family home every week for an hour needs to be tactful and respectful and maintain a friendly distance from the mother-baby couple in order not to be intrusive. Finding the appropriate friendly attitude whilst also maintaining a respectful distance from the family is one of the most difficult aspects of the role of the observer in infant observation. One cannot be detached, but one also needs to avoid being too intrusive. Similar qualities are required from the therapist, who needs tact and respect and the capacity to be emotionally involved, yet also separate from the patient. Final section is about making the case for ongoing observational experience. My perspective is a developmental one that takes account of the ongoing impact of the real environment as well as of internal forces throughout infancy, childhood, adolescence and beyond. What happens in infancy is crucial, but what happens to the child as a toddler, then during the phallic narcissistic phase, the Oedipal phase, in latency, puberty and adolescence, all those things are also crucially important to the developmental fate of that person. Although infant observation is extremely valuable as a preparation for becoming a therapist or an analyst, and as a personal learning experience to enrich our understanding of analytic patients, it does offer a limited developmental viewpoint. Ideally, observation of children at other levels of development beyond the age of infancy offers the widest perspective for understanding patients. For example, when I experienced strong feelings of frustration with an adult patient, I found that I could regain some empathy and find a way out of the sadomasochistic impasse by picturing the patient as a panicky toddler in a tantrum, stamping her feet in a rage and struggling to get away from a restraining mother. Similarly, an image often comes to my mind of a young child observed by Anna Freud in the nursery school who had just begun to master using the toilet. The child, who a short time earlier sometimes had accidents on the floor, suddenly became scathing of others who had not yet mastered this developmental step. Her haughty attack on the less advanced child was due to her fear of regression, her needs to defend against instinctual wishes for fear of losing mastery of a newly hard-won skill, and her need to protect herself from superego shame and guilt. With patients of all ages, one can see a similar mechanism at work when they are contemptuous of someone who does something that they have only recently, with hard work, begun to change in themselves. Images of older children, too, can help one to gain deeper understanding of patients' dilemmas. For example, the adult patient who is really more like a latency child, focused on work issues and avoiding the confusions of sexuality. The conflictual state of mind in some adult patients prior to holiday breaks, and especially during the termination of a treatment, can bring to mind the image of an adolescent struggling with the wish both to stay as a child as well as to grow up, be independent and leave home. I'm sure we could all think of many similar examples of how observations of children and adolescents help us understand and empathise better with our patients. A potential pitfall of infant observation is the idea that what we see in the baby is exactly the same as what we see in the regressed aspects of an adolescent or an adult patient. But it is extremely important to remember that the adult or the adolescent is not a baby or child. He is an adult, or becoming one, however many baby-like or childlike aspects he may have. It's vital to remember the difference between the actual observed baby and the infantile aspects in the older patient in our consulting room, which Stern calls the analytically reconstructed clinical infant. There is a risk of infantilizing the patient if images of infancy and childhood are too directly equated with the adult patient. Child psychotherapists are very well aware that most adolescents will react very adversely to interpretations about their infantile states unless offered with extreme tact and at the right moment. Because of the developmentally appropriate conflict over regression in adolescence, such interpretations are likely to heighten resistance and therefore be counterproductive. I will end with some thoughts by my Finnish colleague, Raija. She made a creative link between baby observation and Winnicott's use of the tongue depressor in what he called the set situation in his paper of his 1941 paper. As you know, Winnicott put a tiny tongue depressor on his desk and asked the mother to place the baby in such a way that the baby could handle it if he wanted to. By watching how the baby reacted in this set situation, Winnicott could observe when the baby became anxious and how the anxiety was dealt with. Raija suggests that Winnicott's set situation and the experience of being an observer in a baby observation also correspond to the psychoanalytic situation. She wrote, quotes, "Adults become familiar with new ideas, just like an infant placed in the tongue depressor situation. When one is interested in psychoanalysis, one takes what is offered and what one finds. One does not impose one's own preconceived ideas upon the psychoanalytic situation. And I would say the same for mother-infant observation. Don't influence the observation situation, don't strive to prove a point, but live within it and experience what it has to offer. At its best, infant observation is one of the most creative experiences possible, just as the tiny shiny tongue depressor can be for the baby. First, one is unsure about it, but when it is in the mouth, chewed and sucked, it leaves something inside us which we want to experience again and again." End of quote. As you can see, Raija was very moved by her baby observation experiences, and she and I hope that her enthusiasm will be sufficiently contagious to enable baby observation to become an integral part of the psychoanalytic training in Finland, just as it is for us in Britain. And we would likewise hope that psychoanalytic societies in other countries might consider adding mother-infant observation as an integral part of their trainings for the unique richness that it has to offer.